Problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about stroke. When I left off last week, I was talking about the different things that can cause somebody to have a stroke and how we go about evaluating them, so on and so forth. I'm continue in that with that discussion. However, I have one correction that I need to make. I spent quite a long time last week talking about polycythemia vera versus uh, essential thrombocythemia, and I kept talking about pancytopenia. Well, pancytopenia is not associated with the ischemic stroke. However, what I meant to say was pancytosis. Pancytosis is when the red cell is high, the platelet is high, and the white cell is high. That's pancytosis. Pancytopenia is when the red cell is low, the white count is low, the platelet is low, and I kept mentioning pancytopenia. In fact, what I meant to say was pancytosis, which is when, of course, all these three cells lines are high. That's what I meant to say, and so I wanted to correct that. However, to continue the discussion, I talk about the problem associated with hypertension. Why is hypertension so high? More than 100 million folks in this country have it. And sure enough, this last week, an email came out in my little cell phone, which I came out from the so-called AMA morning round. That's, you could see that on it's a weekend edition, and you could get it online. And they talk about the fact that of the 100 million folks that have hypertension, and the heading was 3 steps to achieve BP control in your patients. And the article went to say that of the 100 million folks with hypertension, less than 50% of them are being controlled. Okay, and I kept talking about that, and I wanted to share that with you, that in fact what I was telling you is in fact correct. And then before I proceed, I want to make another point, and that is to say that in this country, of all the developed countries in the world, more women die during pregnancy than any other developed country in the world. Okay, and the reason, again, an article came out yesterday saying clearly, again, through the AMA, there are 3 things that's causing it. Elevated blood pressure associated with preeclampsia, bleeding, and of course, and clotting. Those 3 things: clot, bleeding, and hypertension problem. These are the 3 things that cause more women to die during pregnancy than any other developed country in the world. And because of that, I brought this sheet up that to show you why I think this is going on. The blood pressure issue is clear, that it's not being controlled. And of course, if the woman's blood pressure is very sky high during delivery because of preeclampsia, she could have a stroke or a heart attack or what have you and die because of that. That's one issue. The next problem is, let's talk about the clotting issue. Over here, everything you see in yellow, except this one at the bottom, can cause an individual to clot. This can represent predisposition for somebody to clot. These, we call them thrombophilia. Hundreds of millions of people are walking around with these things that are abnormal in the blood, and they don't know anything about it. Okay, and then when a woman is pregnant, the thing that she has to have in good quantity in order for her to carry the baby, the fetus to term, is the estrogen level has to be high. And of course, every one of these things, there's about 12 of them. If you have this abnormality in your blood and your estrogen level is high, you are at risk at clotting. And the clot can be in the brain, it could be in the extremities, in the low flow system, namely the venous system, or it can be the high flow system. Every single one of these things, okay, antiphospholipid antibody, okay, homocysteine level, lipoprotein A level, protein C, protein S, low protein C, low protein S, low antithrombin 3, factor 5 Leiden antibody, the prothrombin gene abnormality. And over here, the PA1 mutation. Any one of these things can be found in a woman's system. And of course, That's when she's the most vulnerable. Because if you have any one of these things and you take estrogen, either intravenously, subcutaneously, or intramuscularly, or by mouth, you run the risk of clotting, and the clot can be fatal. It doesn't matter, any one of these things. And of course, do people test for these things before the people go to deliver a baby? The answer is no, not that I'm aware of. That's not the standard. Do the people test for these things before they put people on birth control pill? The answer is no, not that I'm aware of. Do people test women who are having a postmenopausal symptom for one of these things before they put them on this estrogenic hormone? The answer is no. Do men who are having prostate cancer issues that they're either going to have surgery, they want to shrink the tumor somewhat, or they cannot be operated upon for one reason or another, they put them on estrogenic hormone, because most of the hormone they give to the men are female hormone type, that they would then bring down the male hormone, then that then causes the prostate cancer to shrink. Do people do that? No. Just within the last 2 months, 2 patients of mine have prostate cancer. Okay, both of them were started on hormone without these things being tested. When I saw the patient, I quickly turned around, spoke to the urologists. They were very kind and listened to me, and I tested them. One guy had 2 abnormalities. He had traveled from here to New Orleans on vacation. I contacted him by phone. I said, as soon as you get back, come in because I need to do something. And sure enough, these tests were positive. He didn't even wait until his vacation was over. He showed up in the office unexpectedly, and I had to put him on Xarelto. Okay, and he was on prostate hormone. He was about to have surgery. Another gentleman, the same thing happened. I had to again test him because I know they were going. Sure enough, he was positive. Without any doubt, they were going to clot because of the hormone they were getting. They have enough problem with the prostate cancer. Now they got the hormone, which is the proper treatment for them, but nobody bothered to test them to see if they have a thrombophilia, which is an abnormality in the circulating blood that can cause them to clot or have a stroke or what have you, have a DVT or pulmonary embolism or what have you. This stuff is crucial. Another point that I didn't check those things. There are several cancer markers on this sheet. I put these sheets together myself over the 40 years that I've been practicing. There are more than 200 different tests there. There's hardly any disease known to mankind in this part of the world that can be diagnosed using this sheet right here, if you know what to do. Okay? Now, there's several cancer markers here. CEA, CA125, CA19.9. All these are cancer markers. If any one person has a cancer, that person, the cancer can cause the person to stroke, the cancer can cause the person to have a clot in the legs, a clot in the lung as well. It would say also, well, anyone with any form of cancer, doesn't matter the type of cancer, can be diagnosed with a condition called Trousseau syndrome. Dr. Trousseau was a surgeon a French surgeon in the 1800s who diagnosed Trousseau syndrome in a patient who had cancer of the pancreas, who then clotted. And unfortunately, Dr. Trousseau himself subsequently died with the same disease, with cancer of the stomach. How about that? He did not die of cancer of the pancreas that some people are confusing. He diagnosed the first case in cancer of the pancreas, but he himself, unfortunately, lost his life via the same syndrome that he had discovered with clotting, etc., because of a cancer of the stomach, and he died from that. Okay, so any cancer whatsoever, when somebody presents with a stroke, they have a stroke, but you can't just assume the stroke is the stroke. There may be other underlying reasons for the stroke, so one has to be very thorough to evaluate the patient. Furthermore, if the person does have a clot because of Trousseau syndrome, there are things one cannot do to treat the clot. You can't give this patient Coumadin because the Coumadin will not work. I mean, I don't want to bore you and go on and be too fancy. The fact is to say, Coumadin, which is a blood thinner, fantastic blood thinner. In fact, the first one that was discovered, I think subsequently happened, you cannot treat somebody with Trousseau syndrome with Coumadin because it is the cells, the cancer cells themselves, that are producing a coagulant material. The coagulant material is then being secreted into the bloodstream, rendering it hypercoagulable, and the person can clot. Coumadin does nothing for that. So you have to know these things. Can't treat that if you don't know these things. Suffice it to say, however, every one of these things can cause somebody to have a stroke. I mentioned HIV/AIDS. How do you go from HIV/AIDS to a stroke? Well, when you have HIV/AIDS, you may wind up with AIDS nephropathy, meaning that AIDS that's affect the kidney. Once you have AIDS nephropathy, inevitably you're going to pour out tons of protein in the urine. When you do so, right here, this little one, protein S, right there, protein S is going to be coming pouring out of the urine because of AIDS nephropathy, and the blood becomes too thick and you stroke, just like that. Okay? If you have, how do you go from certain, why do we then test the urine, as I was talking about last week, the different tests for protein, albumin in particular? Because if you're pouring out, if you have any condition that affects your kidney, that can cause you to be losing a lot of protein in the urine, this is why it's important to test the urine for protein, in particular albumin, you could stroke because of it. Why? Because you part of the protein that you're pouring out may very well be protein C or may very well be protein S. How about that? Because of that, you become hypercoagulable. You could stroke just like that. And it doesn't have to be in the brain. The stroke could be, the clot can be in the leg, could be in the lung, could be in the abdominal circulation. Okay? So therefore, these are stuff that you must know. Several years ago, I was calling consultation at White Plain Hospital to see a 76-year-old lady who had a clot in her lung. So I went as a consultant to see the patient, talk about a very nice lady, and I decided, even though she's 76 years old, she's a woman, so let me do her anti-cardiolipin antibody. But when I take the history from her, she told me she had a clot when she had her first child, a clot when she had a second child, a clot when she had a third child. She's been having clot over the years. She got married, has her first child, and when she was 30, she clotted. She survived that. She had another clot with the second child. She survived that. The third child was okay. Then subsequently, spontaneously, she clotted again. She survived all that stuff. Now she's wound up in the hospital with another clot. Guess what happened? I went ahead and ordered an anti-cardiolipin antibody because I was doing a hypercoagulable workup completely to see what can cause this from happening. Guess what? It was because of the anti-cardiolipin antibody. Not only that, at 76, her IgM was very high, meaning that she was very actively producing the anti-cardiolipin antibody from the pregnancies that she was exposed to years ago. IgM is chronic. IgG is chronic. IgM is active. She was packed, a very high level of the IgM of this abnormality. And that's why she clotted. And she was clotting all this time. You can't make this thing up. The IgM was very high, meaning that she was actively sick with that process, as opposed to IgG, which meant that she had the problem. So this is serious business. That's why I put the sheets up there for you. And also, you need to know, one of the most common cause of infertility in women happen to be some of these things as well. And it is now well known by the fertility gynecologists, obstetrician, they know about this now. So now, because the reason why when you have these things in your system and the woman is trying to get pregnant, she's developing mini clots in the circulation of the placenta that clot the circulation, cut off oxygen, and you have spontaneous abortion that way. And furthermore, even to get pregnant, the little clot that's occurring is preventing pregnancy to occur as well. How about that? And then now, nationally and internationally, now it is known automatically these these women are on aspirin and other material as part of the treatment. And I have done over the years several. I had a patient that was so fortunate sometime this year. This young man was about 12, 13 years old now. The mother brought him by the office. They rang the bell because they were in the neighborhood seeing a family at the hospital. And to see me, hug me, and say hello. He's now a very talented young musician. And the reason why I'm telling you this story, this lady could not get pregnant no matter what, no matter how hard she tried. She and her husband tried. And then one day, because I'm a physician for the family, they brought her over to me to tell me what was going on, blah, 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 blah. I said, well, why don't I evaluate her? And guess what? I evaluated her. She had an thrombophilia. I treated the thrombophilia. 3 months later, she got pregnant, and now their son is 12 years old and doing fantastic. It's such a big, he's bigger than me at age 12. You could figure a very highly talented musician. And he put me, some of his music is on the cell phone right here. Brilliant. He plays the trumpet, he plays the saxophone, he plays the violin, and he plays the piano. You can't make this up. He's that talented as a young musician. So this thing is real. So I wanted to show you these things so as to let you know that you have to keep all these things in mind when you see a stroke. It's not just hypertension. It's not just diabetes. It's not just high cholesterol. Yes, these things are well known as predisposing factors, but all these other stuff are causing stroke and clot all over the place as well. Okay? Now that I tell you all that, let us now begin to evaluate someone who presents with stroke. Either they're paralyzed, they're aphasic, they cannot talk. Aphasia, I mean they cannot talk, or they're weak in one arm, or the leg and the arm on one side, or whatever. You have to understand, if you have the stroke on the left side of the brain, the paralysis is going to occur on the right side and vice versa, okay? So I just want to make that absolutely clear. So what do? We finish our exam. We do all these tests. Some of them are very fancy, some of them are not. Some of them are just common tests that I just talked about. The EKG is very important, because if somebody is having atrial fibrillation, then atrial fibrillation can be picked up not only in the physical exam, also by the EKG. Then you know atrial fibrillation can cause somebody to stroke, and I talked about that, how that occurs 2 shows ago. If somebody is having severe congestive heart failure, which can be found on physical exam as well as on echocardiogram, chest X-ray, whatever, this individual can also have stroke, get predisposed to stroke like that. If somebody comes to you, they complain of severe headache, and the blood pressure may be perfectly normal, but they may have something in the brain that's causing the headache. Namely, they may have an aneurysm, or they may have other things that are bleeding slowly that can cause them to be having the headache, or for that matter, it could be a tumor, God knows why. So you got to evaluate it. Okay. So now we do all that stuff. We did all the fancy blood tests, all the routine blood tests. Now we're going to do the first thing. You're going to do a CAT scan of the brain. Why a CAT scan of the brain? Well, it's easier to get, it's quick and fast, and but what you got to remember, what are you looking for in the CAT scan of the brain? You're looking for 2 things. You're looking for blood in the brain, acute blood in the brain, or you're looking for a tumor in the brain, or you're looking for an old stroke. But an acute non-bleeding stroke will not be seen on the CAT scan of the brain. That's exactly correct. It takes about a week or longer before the stroke. That's not a bleeding stroke. There's no tumor involved. There's no other abnormalities will show up. We do it anyway because as we're approaching the patient is going to need to be treated right away. Once, because we have to make a fast and quick decision even before the neurologists get there that we're going to call. Even before the neurosurgeons that we're going to call, if we're going to call them, we have to make a quick decision. So therefore, we need to know, is the patient bleeding? If the patient is bleeding in the brain, we cannot give them aspirin. We cannot give them TPA. So therefore, ghost bleeding I'm talking about. So we need the CAT scan help us there. If they have a brain tumor, we can see it. If they have a minimal abnormality, the radiologist can see it. If they had previous stroke, they can see it. But if they have an acute ischemic stroke, the CAT scan of the brain will not tell you. So you do that to quickly, so that you could start the patient on some aspirin. After you set up all your evaluation, the patient get oxygen, they get all the blood tests, he's cooking, EKGs, order, chest X-ray, blah 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 blah. You got to move fast because you don't have time. You have to make quick and fast decision to know how long this has been going on as well, because there's a specific time limit that you could prevent the stroke from getting worse or improve it if certain intervention gets started, such as giving the patient TPA. You could dissolve the clot within 6 to 8 hours thereabout. Some people say as long as 12 hours or so. But those things, you need the help of a neurologist to get started on that. But you, the doctor in the emergency room or in the office, you got to get started. The key thing is to get that patient to an emergency room as fast as you can. And then once you get there, then the ER doctor has to make quick decision. Or you, the doctor, follow your patient in the ER like I do. You have to make quick decision. Now that you've done that, you get the patient started on aspirin, and I'll tell you, that's not a long story, the dose of aspirin. I'll tell you that, what that is. That's going to create some controversy, but that's okay. And then you got to do an MRI and MRA right there in the ER. You get your CAT scan out first. You get your intervention started. Make sure the patient vital signs are stable. Patient is getting some oxygen. Then God give you plenty of time now to relax. Take a deep breath. Call the neurologist. He or she is in her way. And order an MRI and MRA. The MRI of the brain will tell you if you have an acute ischemic stroke right there and then. And the MRA will evaluate the vessels of the brain for you to make sure you don't have an aneurysm that has ruptured and you don't have other issues that's going on in the patient's brain. You take a good look at the carotid arteries as well. So those are the tests: the CAT scan of the brain, MRI, MRA. Okay, and then you put out a call for your neurologist that's going to rush to the ER to really, because neurological problem acutely is taken care of by the neurologist and or, if needed, a neurosurgeon. Okay? But the doctor at the front line that's going to first get involved is the physician in the emergency room. You take the history from the patient. If the patient cannot give you the history because the patient is aphasic, the family give you the history. And then you have to make quick decision how to move forward because you don't have much time. There's no time to waste. Okay? And then you have your neurologist is coming. Now, I mentioned aspirin. Now, this is going to be extremely important, but extremely controversial. But I'm going to say it anyway. Now, you got somebody who's having a stroke. What they need more than anything else is to get that clot out of the way, or what's causing the clot out of the way, and they need perfusion of the brain. Well, all of us, human beings, were born with a substance called prostacyclin. Prostacyclin is a God-given vasodilator that is located in the vessel of all arteries to keep those vessels open. Prostacyclin. Keep that in mind. It's crucial because you need the vessel to be open so that blood can go through, because that's the key involved in the treatment. Prostacyclin does that. That's a God-given vasodilator. Then you're going to get the patient some aspirin to block the aggregation of platelets that's causing the stroke in the first place. If it's not a ruptured aneurysm, I'm talking about an ischemic stroke, or where there's a clot involved, because there are different types of stroke, and I mentioned those before. But we don't know that yet at this point. All we know is that our patient is having a stroke. Tell us a history that happened 2 or 3 hours ago, and we must move. If you go to any emergency room across the United States, I can guarantee you this patient is going to get 2 aspirin. How about that? Okay, 2 aspirin. Let's stick with the aspirin for a moment. There's a whole lot of stuff that I'm going to tell you before I finish this story that's going to make your legs shake. But let's stick with the aspirin. What is the 2 aspirin going to do for the patient? The idea is to prevent platelet aggregation without interfering with the dilating of the vessel. But guess what? This is exactly what the 2 aspirin is going to do. It's going to prevent the aggregation of the platelet, but it's going to nullify the effect of prostacyclin because the 2 aspirin is too much. Why? Because there's a substance called thromboxane A2. When you give somebody aspirin, you are secreting, as you break the clot that's forming, you are secreting a tremendous amount of, you have to block thromboxane A2 to do that, to achieve that. But when you give too much aspirin, everything that the thromboxane A2 is secreting, my friend, are vasoconstrictors. All of them. There's quite a long list of them. All this material that the thromboxane A2 that you just use the aspirin to put into action happen to be vasoconstrictors. Therefore, the more aspirin you give, the more vasoconstrictors you are secreting. The more vasoconstrictor you are secreting, the more that you're rendering prostacyclin nothing. It can't do anything for you. So you're basically making the situation worse. I know that sounds awful to say, but it's happened to be the absolute, complete scientific truth. These people don't understand platelet physiology. They're great doctors, but they don't understand platelet physiology. Therefore, they don't understand. They don't mean to do any harm, but they don't understand. All you need is 1 baby aspirin. And the reason why you're using 1 baby aspirin, because there's no aspirin that's less than that. 1 baby aspirin is capable of blocking that clot completely. You can't understand that. 1 baby aspirin, 81 milligram, is capable of completely preventing the aggregation of the platelet inside that plaque. Do it completely without affecting the effect of prostacyclin. Won't touch it. So therefore, your vessel stays open, your native vasodilator is working for you, you have a tremendous chance of doing better. But when you get that 2 aspirin, you are over killing it. You're overdoing it. I'm serious. I'm 1,000,000,000% correct, because the more aggressively you block thromboxane A2, the more vasoconstricting material you are secreting from the thromboxane A2, preventing the situation to get better, likely to make it worse. I'm stopping here. Next week, I'll continue to talk about this. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.